Good evening, everyone. I, Nitesh Bansal, welcome you all to our 11th SIPWEB in the series of our free webinar started by Society of Indian Physiotherapy. It gives me immense pleasure to welcome you all today on our 11th edition, where we are going to talk about rehabilitating the elite badminton player and bowler following a rotator cuff injury. When can they return to competitive sports? And to talk about this important topic, we have India's best sports physiotherapist as on date. So without taking much time, once again, I, Nitesh Bansal, the Secretary of Society of Indian Physiotherapists, welcome you all today evening for this 11th webinar of ours. Before I start the presentation and invite my speaker, it's my duty to introduce to you one of the most known name in Indian physiotherapy, the sports physiotherapy field, Nitin Patel, who needs actually no introduction, but as a formality, I must introduce to you of his credential before you. Nitin graduated from Baroda University. After that, went to Nottingham University to finish his MSc in sports medicine. His interest and expertise in sports got him back to India, where he started working with Board for Cricket Control in India, that's BCCI, as a head physiotherapist. All of us are aware he has been a physiotherapist for Indian national cricket team. His association with Mumbai Indians is also not a surprise. All of us are very much aware. Currently, he is working as a head physiotherapist for BCCI. With these words, let me welcome you and present to you Nitin Patel. Hi, Nitin.
Hi, Nitesh. How are you?
I'm good. How are you doing today?
Very good, very good. Sorry, I've done a stopgap arrangement. Since the time I committed, my circumstances have changed, but I'm fulfilling my commitment. I'm sitting in some remote place in South Gujarat for some family circumstances, but yes, we're ready to go.
Thanks a lot for making up to it. And I know how difficult time it is for you, and I know I'm personally aware of this circumstances which you're going through. Anyways, thank you so much for making all these efforts to come across and talk to your audience today and talk about something very special, a rotator cuff injury, which I'm sure all of us are aware, and they come across in their usual clinical practice. And hearing from you for a bowler's perspective, I think that's going to be one of the most important learning what we are going to have in today's series. So without taking much time, Nitin, I will leave the stage to you. We'll have your presentation on the screen. Let me know which looks fine to you. Is it visible, Nitin?
Yeah, I can see it.
So over to you, Nitin.
Sure. So good evening, ladies and gentlemen. Today we're going to speak on rehabbing a rotator cuff injury. Normally in cricket, we get rotator cuff injuries in throwing related issues or bowling related issues or diving related issues. Mainly with the invention of the T20 version of the game, mainly it's a combination of throwing and diving. Basically, they just, because of the higher intensity of the sport, they go and injure their rotator cuff. Next slide, please. Okay. So the normal anatomical orientation of I just want to give you a glimpse of what's the normal orientation of the scapula and the shoulder. So basically, the scapula rotated around 20 degrees upward rotation. Next slide, please. And if you see from the side view, it is inclined around 20 degrees of forward tilt. Next slide, please. And say basically what happens is, why I'm telling you the normal mechanics is that when one has to do an abduction or a flexion or any movements of the shoulder, the scapula per se has to stabilize the glenohumeral joint in a position, in an optimum position for the clearance of the head of the humerus in the glenoid. So when we do a flexion or when we do an abduction, there is an upward rotation of the scapula and a posterior tilt of the scapula. That will allow an optimal clearance of the glenoid of the glenoid for the humerus, head of the humerus. Next slide, please. What stabilizes the head of the humerus in the glenoid. In the transverse plane, there is the subscapularis, and posteriorly, you've got the infraspinatus. So the antero-posterior stabilization of the glenohumeral joint is by the rotator cuff per se. Subscapularis in the front, infraspinatus at the back. If you look at the stabilization in the superior inferior direction of the glenohumeral joint, then basically you're looking at the downward pull is by the rotator cuff which is giving a downward pull, and the deltoid which is giving an upward pull. Okay, so stabilizing anterior posterior rotator cuff, also downward pull is by the rotator cuff. And imagine if someone has got a rotator cuff tear, what will go wrong? Next slide, please. So if someone has got a rotator cuff tear, then the deltoid will be pulling it up more. The force of the deltoid will be more in comparison to the downward pulling force of the rotator cuff, and then you will get an impingement. So impingement for us is a symptom and not a problem. So impingement is secondary to something. So we need to find out impingement is secondary to what? Whether impingement is secondary to a cuff tear, a labral tear, or is it because of a glenohumeral internal rotation deficit, or it is just muscle patterning that the bigger muscles, the major muscles are tight and the smaller muscles are weak. Next slide, please. So here I'm talking about the major muscles. I'm talking about the local muscle system. So these are the stabilizers of your glenohumeral joint. The stabilizers of the glenohumeral joint are subscapularis, supraspinatus on top, infraspinatus and teres minor at the back, and the long head of biceps in the front. So that's the glenohumeral joint per se. If we look at the scapulothoracic joint per se, you've got the upper traps, you've got the lower traps, you've got the middle traps, and you've got the serratus anterior, which comes and creates that upward rotation force, as well as a posterior tilting force for clearing the glenoid for the humerus. Next slide, please. These are the muscles which create the movement. The earlier slide, the muscles were to stabilize the glenohumeral joint. These muscles are creating the movement. So basically a deltoid will create the movement of abduction. A latissimus dorsi is going to create a movement of a climbing action. A pectoralis major is going to create a movement. Similarly, the levator scapulae, the rhomboids, the pex minor, the latissimus dorsi, they all create a movement at the scapula. So basically these are movers, those are stabilizers. Next slide, please. And as I said in the first few slides, basically when we do a flexion or an abduction, there is a posterior tilt of the head, posterior tilt of the scapula. There is an upward rotation of the scapula, and there is a depression and protraction of the scapula. So basically this knowledge is required when we are doing a rehab of a rotator cuff. What movements we need to facilitate for the scapula or the glenohumeral joint, and what movements we need to inhibit for the abnormal muscle patterning of the scapula or the glenohumeral joint. The reason why we need this knowledge is because we deal with athletes who are doing a certain type of movement for long periods. They develop muscle patterning in the sense that some muscles will get tight, some muscles will get weak. And on top of that, they have a rotator cuff tear. So basically, you need to take care, whilst you're rehabbing a rotator cuff tear, you need to take care of those muscle patternings as well. Otherwise, you won't be taking good steps in your rehab process. So that is why we need to have the knowledge of this rotator cuff. Next slide, please. Okay, so what happens when we've got a rotator cuff tear? I'm not going to talk about how we diagnose it. I'm only going to talk about when we've already diagnosed the rotator cuff tear and when we are in a rehab phase. So normally in the rehab phase, if you divide the rehab phase into a few stages, first phase will be a protection phase where the tissues are healing. So you need to respect those healing tissues. You cannot be doing a movement which is which is going to disturb the healing process. For example, if I've got the head of the humerus in the socket, in the glenoid, and I've got an anterior tear, I've got a tear of the subscapularis. So now I cannot do a movement which is going to stretch those tissues forwards, because that will disturb the healing. At the same time, I want a good contraction of the entire rotator cuff. So basically the point is, I don't want to create any shear force while the tissues are healing. So in this phase, what we do is we make use of co-contraction. So co-contraction is basically you make use of all the muscles working around. So all the rotator cuffs will be working based on the amount of the movement which is allowed by the doctor, or which is allowed as per the healing tissues. So here I've extrapolated this data from a surgical case where it was a repair of anterior repair done, and the doctor had only allowed less than 90 degrees in the first stage, and it was only about 45 degrees of co-contraction required. So 45 degrees of external rotation range. Next slide, please. So here, if you see, I am not creating any shear force by any other movements. If I do an isolated one directional work, I will create a shear force, because if I'm doing a TheraBand work, my head of the humerus will be coming forwards into my glenoid. I don't want that. So basically I'm in that safe range, and I'm doing all sort of co-contraction work where all the muscles of the rotator cuff are working. Okay, just co-contraction. This player is 3 weeks after his surgery, and we have started co-contraction work. Next slide, please. Okay, again, we are not going into that risky range of more than 90 degrees. So we are playing below 90 degrees, and we are doing co-contraction work. Can you play the slide, please? Yeah. So basically, we're doing co-contraction work in a safer range, facilitating the scapular movements, and we are doing a co-contraction work for the entire group. Next slide, please. Again, similar. You are creating stability here, but as you create stability, you develop some co-contraction work. So his injured hand is the right side, but he is lifting the left hand. So he is creating a co-contraction work on the right side. Can you think there is no shear force happening? It is just all the muscles working, and they are working and holding the head of the humerus in the glenoid. Next slide, please. We have progressed it to around 45 degrees of range. Similarly, but we have progressed it to around 45 degrees of range. Here, what we are doing is we are integrating the kinetic chain. We are integrating the kinetic chain as well. So we are integrating the posterior kinetic chain into this thing, into the rehab. So basically, what we do is we do a post-mortem of what is required for the bowling. He is a bowler. So he is required to bowl at the end of his rehab. So we do a post-mortem, and we try to integrate these movements in the very early stages without taking the risk. We are not taking the risk of having that shear force. So without taking the risk, we are integrating the kinetic chain movements. Next slide, please. So just to give you a glimpse of what muscles are connected via the kinetic chain. So here you can see the posterior chain circles around your body and goes into onto the same side again, onto the top slide. And to the bottom slide, you can see that the lower traps is connected via fascia to your thoracodorsal fascia, then to your glutes, and then goes down to the kinetic chain. So we make use of these kinetic chains early on, whilst the tissues are healing. We don't need to wait for 5-6 weeks for the tissues to heal, and then we start on all the activities. At very early stages, we start on respecting the healing tissues. Next slide, please. Here we have progressed it to 90 degrees. But the same time, if you see, his right hand is is on the ball, whereas he's standing on the left side. So he's activating the posterior kinetic chain. Imagine he's to bowl, he's a right arm bowler. So he's to bowl, he's standing on his left side and he's bowling. So this is just a breakdown of his bowling action. At the same time, the shoulder is working in a co-contraction phase. Yeah. Next slide, please. Okay, similar. You are activating the core, you are activating the rotator cuff for a co-contraction, you are activating the lower kinetic chain as well in a more functional way, where he demands standing on his left side and bowling on with his right side. Next slide, please. Again, going into more higher ranges. Again, see, we have integrated the kinetic chain, more functional movements, and he is doing the co-contraction again in that. This is all in phase 1. Week 3 to week 5, 6. The player is respecting the healing tissues, but at the same time activating the kinetic chain. Next slide, please. Okay. Now getting into, again, a co-contraction, but getting into more, a bit more higher positions, more than 90 degrees. We have to get that range as well simultaneously. So we just co-contraction, and co-contraction, and we go to the higher ranges and then ask for the co-contraction again. So we started from lower degrees, 90 degrees, and then higher degrees co-contraction. Next slide, please. Again, co-contraction, working with the core. You can be more innovative by asking him to lift one leg up. Try to get the kinetic chain as much as possible. Next slide, please. Again, co-contraction, kinetic chain linkage, working with the core stability, posterior chain. All these will be assets when you come to the end stage of rehab. If you want a problem-free end stage of rehab, all these are assets. Next slide, please. Okay, co-contraction again, but adding a little bit of sudden movements. You're not taking much of a risk here by doing this. You're just adding a bit of sudden movements with the co-contraction. Yeah. Good. Next slide, please. Okay. Then when we reach to the next stage, we are allowed to have more ranges and allowed to have more co-contraction, more than 90 degrees range co-contraction. And then we are allowed to have the rotational component as well, because now the tissues are healed. Now you need to give an optimal stimulus to get them stronger. So in this stage, we progress our co-contraction work beyond 90 degrees, but at the same time, we start our rotator cuff exercises as well, the unidirectional rotator cuff exercises. So your external rotators, your internal rotators, external at 90, internal at 90, above 90, based on the healing tissues. Next slide, please. Okay. Adding some global muscles now coming up, because you've already built the base of the building. So now the bigger muscles can start acting onto that base. So you are activating the pecs, you are getting the deltoids working, the triceps working, all those. Adding the global, the bigger muscles, which are going to create the movement. Next slide, please. Yeah. This is your simple rotator cuff. External rotation. You can do internal rotation as well. Next slide, please. Again, this is just in preparation to running. It is just a movement. It is nothing to do with the shoulder. But when I come to the end stages, if my movements are clear with my running, then I will have less shear force on my shoulder. If my whole kinetic chain is linked properly, then I'll have less force on the shoulder. If this muscles, the pecs, your core, your rectus abdominis, and the external oblique, internal oblique, and leading into your lower leg, if they have been activated early on, then you will have less load on the shoulders whilst you return to the throwing phase or the bowling phase. Next slide, please. We have added the co-contraction here now at around 90 degrees. Earlier, we were at around 0 degrees or 45 degrees. We have added it at around 90 degrees now. Next slide, please. This is co-contraction in the end stages. What happens is when a bowler or a thrower, they have to do they have to transit from that cock-up phase to that acceleration phase of their throwing. That moment where they transit from a cock-up to an acceleration phase, there is a bit of shear force at the glenohumeral joint. So to stabilize that, you go to that specific movement and do those do the co-contraction. So when they return to that throwing phase, they have got less hiccups in the shoulder. Next slide, please. You can play this. Sorry, I think you have to play this, Nitesh. Okay, so basically, okay, it's not playing. So no, basically he leads from top. He goes down and he finishes at his left foot. Can you play this? So basically, I'm just creating the co-contraction in the entire kinetic chain. So going from top, going down, 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 up to the left leg. Let's see. Keep going. I think he will come. No. Okay, fine. Next slide, please. Next slide. Nitesh, I think this is done. Next slide, please. I think, okay, yeah, go. Yeah. So he's finishing till the end. So the shoulder is working till the end. Your co-contraction is working till he finishes. Because what happens is, when they release the ball, they have a traction effect onto that shoulder and the glenohumeral joint opens. So you're training that joint right at the early stages so that when they are into throwing phases or when they are into their bowling phases, that traction effect is taken care of. Next slide, please. Next slide, Nitesh. Okay. Then comes the rotator cuff strengthening, mainly the strengthening the major muscles, you integrating the kinetic chain. Primary focus is on the kinetic chain, posterior chain, because every time they keep on doing this, and they have developed a patterning of the anterior rotator cuff. Sorry, not anterior rotator cuff, anterior chain. So basically, most of them are stronger from the front and weaker at the back. So we utilize this phase of rehab to make them stronger at the back and try to balance the two. Because when they go to their return to throwing phases, return to bowling phases, they're only going to use this concentrically and they're going to use this eccentrically. So they get weaker and weaker in the long run at the back. They get stronger and stronger in the long run in the front. So we take this time at that strength ratio. So we mainly focus on the posterior chain. And then this gives us a lot of confidence into when they are released for playing. We know that we've focused so much on the posterior chain that the chances of recurrences go very little. Next slide, please. Okay, this is a, yeah. So this is basically in preparation to bowling. So just stability at the upper stages and then creating that creating a movement on top of that. So when he catches the ball, he has to stabilize the glenohumeral joint at the top, and then he has to create a movement and activate the whole kinetic chain to generate the force. Next slide, please. Here is a transition from the rehab environment to a ground environment. So he is just going from the full ranges of the co-contraction. This is just a warm-up drill. So basically on this day, he was supposed to bowl. So we integrated this into a warm-up drill. So his warm-up is also taken care, his stability is also taken care, and then he can be bowling after that. Next slide, please. This is just simple strength work. Posterior chain again. Posterior stabilizers of the scapula. Next slide, please. Posterior chain again. Looking at building more strength in the posterior chain. Next slide, please. Okay. Looking at unidirectional stuff. So kinetic chains work in diagonal pattern. So you're looking at unidirectional stuff. Next slide, please. Okay. Now what we do is, here he is working on the external rotators of his glenohumeral joint. With one of our criteria for return to play is the balance between the internal rotators and external rotators of the glenohumeral joint. If the internal rotators are too strong, then the external rotators, then eventually they will lead into an anterior translation, and then the repair will fail, and then they will have problems into the throwing or bowling stage. So we aim to have a ratio of 75% to 100% ratio. So 0.76 ratio of external to internal ratio. So external rotators should be 75% of the internal rotators, which gives us a lot of confidence in them, declaring them for their return to sport stages. So here we first assess what the strength of the external rotators are in comparison to the internal, and then we balance that out by doing external rotation. Next slide, please. This phase, I had to be cautious with my SNCs because here you're working on the anterior chain. When they return to sport, some amount of activation is required because they should not be coming and saying, I cannot feel power in my throw. So just to get that athlete that feeling about, no, I'm strong in my upper body, my deltoids or my pecs, I'll give 1 or 2 weeks of the SNC guys to build up on the major muscles. Next slide, please. Okay. When we return to sport, so basically what we are doing is we are cutting down those movements, the bowling movement or the throwing movement, and we are making that as a drill. So for example, if he is going to bowl, then he will take a ball and then he won't bowl, but he will go and take his stride and then get into his bowling action and come down. So we break down the movements, the bowling action movements into multiple stages, make them drills, and then they will practice it. There is an overlap of these drills into that strength phase. So when they come to return to sport phase, they have already done 3 weeks of these drills. So immediately they can start onto the field. Next slide, please. There's just a sample of a microcycle, what a player goes through in the return to sport phases. So we planned up to Monday to Saturday. They will have skill preparation, then they will have a strength window, and then they'll have a recovery window. We always want to have the skill first before they are tired from the strength work. So skill first, then the strength, and then the recovery phases. Next slide, please. Okay, again, breaking down that throwing action. Sorry, it's a bowling action. So breaking down the bowling action into multiple stages and then giving them as a drill. Imagine, guys, this is not a shoulder activity, but it will help your shoulder a lot because if the entire kinetic chain is working and if it's in sync with the shoulder, then the shoulder will have less load. When they are throwing or when they are bowling, if the force is generated from the lower body or the core, then the shoulder will have less load. So to minimize the problems on the shoulder during the return to play phases, we do all this. Next slide, please. Okay, this is just breaking down the throwing action. Cock-up phase, finish phase. As I said, in the finish phase, there is a lot of traction at the glenohumeral joint. So you need to train that finish phase. You need to just work on that co-contraction or even a push-up plus like a scenario, and then train in that specific position so that you've got less hiccups in the into the return to play phases. Eccentric subscapularis, the last one. Basically, what we do is someone is going to throw a ball from the front, and I have to catch it whilst the ball is going back. So I'm doing an eccentric subscapularis. So the ball is coming, and I have to catch it. At the same time, I'm doing an eccentric external rotation movement by the control of my subscapularis. So this is going to help you in the cock-up phases. Next slide, please. Okay, preparation to throwing. Cock-up phase. This is, we are activating or we are working on his cock-up phase. Got it? Co-contraction, go beyond that because they are not going to throw from here. They're going to rotate their upper back and then throw in that position. So we go into that position and specifically work on that. Next slide, please. Okay, he started bowling now. I'm sorry, it's in a slow-mo. Okay, so basically, the gist of things is that we break down those requirements. We break down the bowling action, we break down the throwing action and integrate that into early stages of rehab. One, respect the healing tissues by using co-contraction and activate those kinetic chains early stages of rehab so that the load is less on the shoulder when they come to the return to play phases. Next slide, please. Okay. In throwing, we start early, in the early stages, we start with lower intensity, lower distance, building it up gradually increasing the distance and the intensity. So basically just first they will be fielding in the nets in a controlled environment. Then they will be fielding in a team warm-up environment where they will have balls coming all from different directions. The angle of the ball is different. Then they will be progressed to this fielding from the outer circle from beyond the 30 yards. So where they will have too many parameters, like the ball will come from different direction, one, but then they have to pick up and throw it with higher intensity to the wicket keeper. So all these will gradually keep on adding one parameter at a time. But the key is overlap of these phases. If I had not started integrating my kinetic chain in my early phases, the phase one, I might have landed up in some issues at the return to play phases. This player, he was back. He had a full thickness stare, 180 degrees. Repair done. He was back into competitive cricket in 3.5 months. Back into his country squad in 3.5 months. This required a lot of planning. We planned it backwards. Say he wanted to play in September and the surgery was done in May. So we had to plan it backwards and we were able to achieve it. The next slide, please. Good. So the gist of things are planning, integrate early kinetic chain, avoid the shear force, allow the healing to take place, and then accelerate later on with your other, rotator cuff exercises or with your major muscles coming in later on. Planning is key. Integrate all the exercises, break down the ends, what are the end requirements, break that down and try to integrate in the early stages. Nitesh?
Thank you, Nitin. Thank you so much. It was a treat. Actually, I never thought that it could be so simple for all of us, like who are not very actively involved with sports physiotherapy. For us also, it seems that it's so simple and such a beautifully you have explained to all of us. And thank you so much for your efforts. I wonder, Nitin, how did you get time to shoot all these videos for us? I mean, I'm sure you must be having
Luckily, it was, I had presented this to a shoulder surgeons conference that was in somewhere around in in June or August, August 2019 or so. There was an Asian shoulder surgeons conference and I had to present this. So luckily I had these videos. So good thing that Kiran agreed to this topic.
Great. Actually, I know how much discussion we have to go back and forth to come back to a common topic, which would interest both of you. And getting both of you together was a hilarious task. And thanks to our founder members who can manage that and have both of you, Nitin and Kiran, together the topic on rehabilitating the rotator cuff. Nitin, I have a quick question which came as a first question. How do you decide to move on to the next phase? You have prescribed the 4 phases in rehabilitation of rotator cuff. How do you decide?
Come again?
How do you decide about when do you move from one phase to another one? Is it a time bound or is it, outcome based? How do you decide on that?
I think it is outcome based. I look at the time bound which the surgeons have given, the doctors have given. Because since they have seen the tissue, the quality of the tissue and the arthroscope, so they are our guiding factors as well. If the surgeon said, okay, 6 weeks, this tissue quality was bad and 6 weeks, we should respect it, and please respect it. No shear forces, but after that, you integrate it. So basically what I do is I sit down with the surgeon and say, okay, fine, the tissue quality was bad, but what is precisely what you want? So basically he said, I don't want any shear forces anteriorly. I said, fine. If I get something out of the shoulder without creating the shear forces, you're happy? He said, I'm happy. So then you just try to improvise on the techniques, and to answer to that question, I think go assessment on a daily basis.
Right. So I think regular assessment and team play actually is the most important. You need to be in consultation with the surgeon or orthopedician who has operated on that, and then take it.
And overlap of proactively act of the second phase. If I'm in the first phase, I know what are my requirements of the second phase. So I'll proactively start adding that into my first phases.
Thank you, Nitin. Thank you so much. I already have a lot of other questions, but I'll come back to you once we have done with Kiran's presentation so that we can have both of you together. Thank you so much, Nitin. Once again, I'm going to come back to you before we hear it, what Kiran has to say. Thank you. Well, I'll come back to you. I'm sure all of us, you also enjoyed the way I enjoyed this presentation by Nitin. So now moving on to our next topic, next speaker, who is Kiran Challagundla. Before he's finished his bachelor's with renowned Manipal University at Manipal, his Bachelor of Physiotherapy, he moved to pursue his master's in orthopedic sports and manual therapy in University of South Australia, Adelaide. Currently, he is a head physiotherapist for Indian badminton team. We all know him, Kiran Challagundla. His contribution towards performance of PV Sindhu has been talked about all over media. Former physiotherapist for Sunrise Riser Hyderabad, Deccan Chargers, the IPL team. So here we have a connection with cricket with Kiran as well. Soccer, Australian Roots football team in Adelaide, Australia, Hyderabad state cricket team, the only certified international course instructor for Asia for the NDS, Neurodynamic Solution Australia. With these words, I take this pleasure and honor to invite Kiran Challagundla with us for this SIPWEB. Thank you, Kiran. Thank you so much for agreeing and taking this SIPWEB with us. Can I request you if you can unmute yourself?
Yeah, can you hear me?
Yes, Kiran, loud and clear. How are you doing today?
Good, all good. And thanks to Nitin for that excellent presentation. I guess it made my work half done or something, I could say. Yeah.
Great, Kiran. So I will not take much time and will not stand. We have a lot to chat and talk when I'll get Kiran and Nitin together on the screen, which will become a very heavy. I mean, nobody could imagine we have best of the sports physiotherapists currently on the same screen talking about the most important injury, the most common injury, rotator cuff. Without taking much time, Kiran, over to you. You may like to share your screen.
Yeah. Can you please give me?
Yes, please do that.
Good. Is it fine?
Yes, yes, it's all okay. Good.
Great. Good evening, friends, and welcome to this webinar on the rotator cuff injury rehab. I guess my friend Nitin, he has given excellent presentation on starting from the initial phase till the back to sport phase of dealing with the rotator cuff injuries. I'll not be dealing much about what you say the post-surgical cases specifically. In general, I'll try to see in this. As we go on, I'll try to explain what I'm trying to say. This is again based on my on-field experience as a sports physiotherapist. It's just as I've been saying, again, I want to repeat that it's mainly based on the experience-based ones rather than more of what is evidence-based. But again, experience, evidence usually both correlate together. Coming to this rotator cuff anatomy, I guess in the previous presentation, you already seen this rotator cuff anatomy. I'll quickly go through these ones. Basically, the rotator cuff muscle actions, all these rotator cuff muscles, they originate from scapula and they invert into the humerus. Their main role is to stabilize the glenohumeral joint by locating the head of humerus into the glenoid cavity. Yeah, that's the minimum basic function of all these. And the main is the sits muscle, subscapularis, supraspinatus, infraspinatus, teres minor. These are the main rotator cuff muscles as you see. And one more which I personally feel is that the long head of biceps, which is not actually a rotator cuff muscle, but at least with my experience, I've seen that it should be given equal importance as rotator cuff muscles when it comes to shoulder rehab. Because if you can see here, you can see the long head of biceps tendon. It's passing underneath the subscapularis and supraspinatus tendons. It's much more closely associated with the shoulder joint or else head of humerus, even underlying the supraspinatus and subscapularis muscles. You can even go to this next one. So you can see it's such a deeply associated tendon. So generally, whenever I am dealing with this, I give a very good importance to this long head of biceps too in association with the rotator cuff muscles. Coming to this clinical assessments, again, I'm not going to this, but these are the most common clinical assessment tests, which I guess all you guys must be doing: the resisted isometrics, empty can and full can test, the painful arc test, Hawkins-Kennedy, Hornblower's test, shoulder drop arm test. But drop arm test is more something like a tape, probably grade 3 something sort of thing. And then we could even go to these associated tests like speed test, O'Brien's test, and Yergason's test, mainly to check with the slap lesions or long head of biceps, and any relevant functional test, whichever you feel are relevant. The general broad line clinical assessment procedure. And coming to this, before I start with my presentation, I'll just show you 2 or 3 videos which have where most badminton movements are involved. I just wanted to show you the badminton movements involved. Just check at the movements. Then I'll come to, because once we know the movement, then we'll come to which muscles we should get involved in these movements. This is our chief coach, Mr. Pulelu Gopichan. So you can just look at some of these movements.
What you will have to do is start off with the first exercise.
Okay, just look at the movements, and especially as we're dealing with rotator cuff, also during the follow through or after the movement, you can look at how much amount of internal rotation keeps on happening in a badminton movement.
It's the first exercise you're doing with 40 seconds of the exercise and 20 to 30 seconds.
Again, we'll go to a few more movements.
Continuously. The second exercise will be this one, where you're doing lots of parallel and then shots. You're going from here, take a stance.
You can see here, the first one was badminton movement where it was more of overhead, but here you can see it's not overhead, it's not underarm. Somewhere around the shoulder, what you say, above head to near just below the chest area. Lots of very, very fast movements and quick reactive movements. Okay, I'll even do this a bit slowly. You can see very quick internal rotation and external movements happening at different directions.
Do it as fast as you can.
Okay, this was the first video. Now I'll go to the second video, a bit more dynamic one. This is the video of Srikanth Kidambi, former, he was world #1 in 2018. Just look at this. This is more of a very, very high level or else very high intensity movement. You can see that the amount of movement happens. And those who have got used to this PNF patterns, you can say during his smashing thing, excellent movement of flexion, abduction, external rotation to extension, adduction, internal rotation, the beautiful pattern. Okay. You can see this. From this flexion, abduction, external rotation to extension, adduction, internal rotation. Those are dealing with PNF patterns while dealing with the sports injuries. Okay. You can see one more stroke, then I'll go to the next video. Okay, this video a bit lengthier one, but I'm stopping here and I'm going to the next video. You can see the previous video where Coach Gopijan sir, he was mainly on the ground. But you can see this video, there is too much in the air, lot of movement, power generating, or player is playing the stroke in the air. We'll go to the, sorry. This is the backhand stroke we call. Okay, just a small video. So you can just remember those three videos. After a couple of slides, I'll come back to those videos. The most common reasons for the rotator cuff injuries, I guess, first, usually in many of the books or else we see poor technique, but generally speaking, technique is something which the physio role has changed where it's like we may not talk about technique, but we might talk about correct activation of muscles while they are doing the movement. Yeah, correct activation of muscles while they are doing the movement. And then you can even go to poor strength of the rotator cuff muscles, but it's like if at all rotator cuff strengthening is missed in their program, I guess it's a blunder, but still if at all it's missed by any chance, that could be one of the reasons. To overuse injuries or else too much activity too early. Suppose after off season, they are coming to on season, especially during now the COVID situation, quite a few players must have taken off. When they're returning to the activity, too much of activity too early rather than giving time for conditioning. That could be one of the reasons. And then you can see the next two, overactive or dominant or too strong agonist muscles. Usually agonist muscles are the ones which are performance muscles, and antagonist muscles or reverse muscles are the ones which are mainly the stabilizing muscles, the basic rule. So overactive or too dominant or too strong agonist muscles and antagonist rotator cuff muscles and stabilizing muscles cannot balance the activity of agonist muscles. Finally, one more reason, weaker agonist or kinetic chain muscles, stabilizing muscles have to do the action of agonists. I'll come to this one by one. Now coming to the rehabilitation approach. Usually we talk about, I guess a friend Nitin, he talked about different phases. I put in a different way. Usually we have about these three phases. First phase is the relative rest and strengthening. Again, strengthening, I'll also come to that one. First, initial phase, just let the inflammation settle down. And I'm not talking necessarily about post-surgical cases also. It could even be initial stage of like rotator cuff tendinitis, tendinopathy, where there is some inflammation and we need to just give time for the muscle to settle down, where don't irritate the tendon too much, the rotator cuff tendon too much, and strengthening. Second stage, we go to strengthening the agonists and synergies, and then releasing the antagonist. I mean, what I mean to say, sorry, it's the strengthening, strengthening the or else activating the kinetic chain muscles. I'll also go to this one, strengthening agonists and synergies, and also if at all any muscles are limiting the role, we need to release those ones especially. I'll come to this one by one, we'll go, then we'll know. Then working on the kinetic chain, that is relative strength and flexibility of this one. Now coming to this initial phase of relative rest and strengthening, generally co-contraction and activation exercises. I guess friend Nitin here has shown really good. Initially, that's what we don't go so much into huge movements, but most of those movements are isometrics and co-contraction exercises. Of course, we can go to strengthening the scapular and shoulder stabilizers. You can even go to it like what you say, serratus anteriors or mid trapezius, lower trapezius, all those ones we can go to it. But good co-contraction exercises and lot of activation, but more of isometric activation exercise. Once we go to that one, then we can go to external rotator and internal rotation exercises at different angles of shoulder flexion and abduction to directly strengthen the rotator cuff muscles. Here, one small thing or a challenging with our badminton players, what we have seen is, if you can see the smash in one of the videos, in that if you can see, the agonists are the anterior chain muscles, and then balancing or antagonists are the posterior chain. Whereas if you remember, we have seen the third video, the backhand video, in that if you can see, the prime movers or agonists are the posterior chain muscles. And probably in those, the antagonists or stabilizing muscles should be the anterior chain muscles. Which means what happens is, in this badminton player, we need to train the muscles, both front muscles also, anterior chain muscles also, we need to train them both as agonists and antagonists, and even posterior chain muscles also, we need to train them as agonists and antagonists, because we don't know whether player wants to play backhand or they want to play the overhead. It depends on the player's preference at that moment of the game. So that's why we need to train the muscles in different ways. It's like isometric, concentric, eccentric. So we need to train internal rotators in concentric way and also in eccentric way. Similarly, external rotators also, we need to train them in isometric way, in concentric way, and also in eccentric way. So that's the major thing which we need to think of in badminton players. And at different angles, you have seen one of the video where the player is jumping and playing. But you can see in our coach Gopichan sir's video, what he has seen. A lot of movements are happening here, which means it's not only the overhead arm, but in different angles also, we might need to think of doing this co-contraction and activating exercises. And of course, during this phase itself, if possible, you can even go to treating any contributing factors or secondary complications which has led to this rotator cuff injury, whether it's posterior capsule stiffness, or whether it's glenohumeral internal rotation deficit, or whether it's cervical joint stiffness, etc., whatever you feel contributing factors. This is an initial time where you can go to those releases or whichever possible. Now coming to the agonist or antagonist concept. This, I guess, I've already told in the slide earlier. Rotator cuff muscles in badminton, rotator cuff muscles might need to perform all types of muscle roles. That means performance muscles, agonists. I'll not say especially rotator cuff muscles should do the agonist, but it's also contributing during the agonist movements. They are also contributing. Versus balance or reverse controlling or antagonist movement. As we have seen in that, when we go to the backhand video, probably the external rotators along with the posterior chain are probably the mainly the agonist movement. So antagonist movement, the role changes to front muscles. Whereas if you go to this overhead action, their probably agonist movement is coming to the front side ones. So antagonist, the muscle changes. So different roles, rotator cuff muscles or else the shoulder girdle muscles plays in this. We need to do this versus stabilizing muscles, synergist or stabilizing muscles or injury prevention muscles. So that's why in different types of rotator cuff muscles and shoulder stabilizing muscles might need to do different types of muscle actions. So lot of variety of exercises are supposed to be done here. And here, this again depends on the technique. There are some players who never go to backhand. They always go to overhead and play. For them, no need of training the posterior chain as an agonist chain muscle action, because they always prefer to do in this way. The antagonist or else the backhand action might be very, very less. Whereas player who plays a lot of this backhand action, probably we need to train the posterior chain as an agonist action also. So that is the second thing to keep in mind. And then here, if you can see this working on the agonist or antagonist concept, again, it's the same thing. Obviously, we have been talking about these rotator cuff muscles, but always shoulder and scapular stabilizing muscles, whether it's serratus, mid traps, lower traps, rhomboids, We should never ignore those actions, but initially we normally come to do that in the initial phase itself, stabilizing all the shoulder movements. Before we go to the rotator cuff, just make sure all the shoulder movements are well balanced, or else we say scapular movements are well balanced. Then we can incorporate the scapular movements with the rotator cuff movement. You can see this subscapular is the main internal rotator, but you can see other shoulder internal rotators. Pectoralis major is also an internal rotator. Teres major is also an internal rotator. Lats are also an internal rotator. Whereas if you can go to the supraspinatus, deltoid is also one of the muscle which helps in supraspinatus. Of course, I mean, here what I'm trying to say is, during the supraspinatus action, it's the deltoid which does the action, but supraspinatus is the one which should be stabilizing the shoulder. Initially also, when the pectoralis majors, teres and lats, all these are working, it's the subscapularis which should do a lot of stabilizing work. And then you can go to this infraspinatus and teres minor. It's mainly posterior deltoid, rhomboids, mid-trapezius and teres major. And if at all you can recollect these anatomy, I mean, if you can roughly go to anatomy dissections, whatever we have done, and just try to roughly remember the size of the muscles. You can see the pec major, the lats, especially these anterior chain muscles, pec major, lats, those are huge muscles. But when we go to these posterior muscles, you can see these rhomboids, mid-traps, teres major, these are very small muscles, relatively, compared to the anterior chain, compared to the anterior muscles. That's why whenever we are dealing with the rehab, while dealing with posterior chain or else stabilizing ones, yes, initially we can concentrate on individual muscles, but rather than concentrating on the muscles, trying to activate the entire posterior chain would always give much better results, because the anterior chain muscles, you can say the anterior deltoid, the pecs, the six-pack muscles, or else the obliques, these are huge muscles, very big size muscles where they can generate a lot of force. We are trying to strengthen only what you say the infraspinatus, teres major, shoulder, external rotators to compensate all this. It's not so easy, because imagine the sheer force applied by this. So that's the reason whenever we are dealing with these posterior chains or else the external rotators, always rather than sticking to one or two individual muscles, it always better to activate the posterior chain. I guess the friend Nitin has shown beautiful exercise of initially how to activate the posterior chain proximally, then trying to incorporate posterior oblique chain with glutes also. He has shown beautifully in that one. That is that one. The working on the kinetic chain concept is what I was saying. In this, different players have different techniques and they use different kinetic chain muscles. So here what happens is, that's what this different anterior chain also, again, it's like, see, it's like, it depends on different techniques by players, because some might go to anterior chain straight away in this way. Some might use more of this anterior oblique chain. You can see these different chains of muscles. Similarly, posterior also, posterior chain, posterior oblique chain. So what we need to do is, that's what you have seen. Initial phases, as we have seen, the most common thing is first going to co-contraction exercise and activation, then going to the rotator cuffs, then going to activating the anterior chain. These are the anterior ones. Similarly, posteriors also, obviously co-contraction in individual muscles we have done, but generally as a rule, usually initial stage, we always go to stabilizing muscles, stabilizing phase, or else what you say, the antagonist phase, where you need to strengthen the antagonist muscles. It's again, our friend Nitin has given the beautiful word. Think of what to do at the end. Start with the reverse of that and come to that one, which means if this is the end, start with the antagonist movement first. But here again in badminton, what we have seen, antagonist movement could be this, it could be this, it could be this, because different angles, different movements might happen. So different antagonist movements we'll be doing. Unfortunately, I don't have specific exercises to, I mean, I have some of the videos, but because of, I didn't want to show the players, I could not show this here. But that's the thing. So different players have different techniques. So they use different kinetic chains, especially because here we can see this, what to say, girls and boys. Boys do lots of jumping in the air. So the chains change slightly compared to girls. Usually in badminton, they don't do so much of playing in the air. Usually standing one. So most of the chain comes here. Whereas boys in the air, they'll jump and they do this. So lot of huge chain going all the way till the lower quarter happens. Boys use a lot more of kinetic chain activation in the muscles. So that's what is the thing of like activating the kinetic chain concept. Yeah, so these are about these rehabilitation approaches as well. We have seen this one, releasing the relative rest and strengthening. Here again, we can see strengthening agonist, antagonist. That's nothing but it's like go to this, if internal rotators, release these ones, agonists, sorry, and then going to strengthening the antagonist. First here, initial, we want to do this external, we want to strengthen the external rotators. So that we are trying to strengthen the agonists, that is external rotators. So these other muscles, reverse muscles, release them, or else the performance muscles. Then finally working kinetic chain, and that is relative strength. And I guess you all also see this, just 1 second. So the kinetic chain, again, you all know this concept. Suppose if you can see this anterior oblique chain. So what the rule goes is, during this kinetic chain, different muscles play different role. If one muscle is weak, then other muscles should do the action, or else if one muscle is stiff, then other muscles should do over movement, or else it should be hypermobile. So which means what happens is, as we go to advanced stages, we try to check different functional tests to check the whole chain, whether the whole chain is working. Sometimes it could be weak core muscles because of his shoulder is overacting, whereas core muscles should act well, but because of weak core muscles, shoulder activity might be overactive. There, it could not be directly because of any problem in the rotator cuff, but it's more because of the chain of muscles which are not working. So when it comes to this chain, that's what it's a big movement. So initially, individual chain muscles will be activating, co-contracting, and teaching the player to activate. Finally, when they're going to return to sport phase, so that entire muscles, all muscles act appropriately. That's what is the meaning of this third one. It's like relative strength and flexibility. That means all the entire chain muscles should be strong enough so that they do their actions smoothly. And entire chain muscles should also be good mobile. Otherwise, if one muscle is stiff, other muscle should be hypermobile. Or if one area is stiff, other area should be hypermobile to do the action. So that's what is the general rehabilitation approach we try to do in this one. Yeah. Yeah. Nitesh, yeah.
Thank you, Kiran, for such another wonderful presentation. We really thoroughly enjoyed it. Gave us a clear perspective from badminton point of view. And I'm sure all our viewers also enjoy. Let me just invite Nitin back to our screen now.
Yeah.
Oh, good to see you, Nitin, at a different place. You have reached to some beach? I'm sorry, you're mute, Nitin.
Can you just unmute yourself?
Sorry, I'm saying I just turned the chair 90 degrees. That's it.
So 90-degree change actually can do such a lovely change. I would never imagine that. And being a sports physiotherapist, I think degrees do matter to both of you.
Correct.
Really. So thanks both of you once again for taking us through such a lovely a discussion about rotator cuff from a bowler's and a badminton point of view. And I think all our viewers are also excited. Before we move on to some serious question, I also want to ask Nitin and Kiran to you. How do you see players? Do you also watch bowler? Or Nitin, do you also watch a badminton player when you, see that in terms of movement? Do you correlate with your individual sports? Or it is just your respective sports?
I think for me, we just are so much into our own sport that I particularly just get so ingrained into it. And then when I see a badminton, oh, it's the same thing. It's nothing different. It's almost the same thing. But as Kiran explained, that there is also a demand going in the reverse direction, which never happens in cricket though. So yeah, it's different. It's slightly different. He opened my eyes. I never realized that they will also have to train specifically for that.
That's an example, like learning never stops. Kiran, what you have to say about that?
Yeah.
Bowler or a batsman?
Yeah. Basically what happens is, whenever we read about, whenever during a study period or something, when we read about biomechanics, most of the times the overhead biomechanics usually correlates a lot, whether it's a tennis serve, or whether it's a volleyball, or whether it's a badminton smash, or whether it's cricket. Of course, we need to respect the individual biomechanics of each and every sport. But usually there will be some common things usually which happens. Because in initial studies, 20 years back, we used to learn these more or less like the PNF patterns. All these overhead sports, these should be the PNF patterns, where it's the basic pattern is flexion, abduction, external rotation to extension, adduction, internal rotation, the basic pattern, D1, D2s, and all those we can say in this way. So that's what, and for me, once we go to that, usually in our this thing, badminton, we even have this video analyst. We have a excellent video analyst with us also. So we keep on sitting with the player, we keep on sitting with coaches, and whenever sit with coaches and players and all those, we keep on seeing this one, all this. And obviously, cricket is something which even almost all the badminton male players also, we keep watching. Even whenever we are abroad during these IPLs and international matches, we keep on watching. So we have lots of discussion about these things also. So it's good to join Nitin also in this one.
Great. I think let me come back to my audience question. One of them I want to ask is, are there any functional tests you perform before you give them a okay to return to a competitive sports? Let me start with Nitin. Do we use any functional test before they need to perform before they are returned to competitive sports?
So yeah, what we do is we do functional as well as we do clinical tests. Functional is checking the stability of the shoulder and also checking the stability of the rotator cuff. As I explained, the ratio of the external to internal matters a lot, and it gives us a lot of confidence, or does not give us confidence, whichever way, but we try to aim that ratio to be 75% external and 200% internal. So 0.75 is external to internal ratio. And that gives us a lot of confidence. Then we also look at checking them functionally on the field in terms of their bowling and throwing. So we sometimes have a speed gun for their bowling to measure what is their actual performance relying on the field. And sometimes we also have a speed gun for the throwing, where we measure their the speed of the throw at 30 yards and the speed of the throw beyond 30 yards.
So basically all these major function what a bowler requires to use. Kiran, how about you? What do you use as a functional test?
Yeah, I mean, if at all I had an option, first thing is whenever we deal with these injuries, the first question or else the first thing we need to confirm is player activating the right muscle during the movement? So for that, ideally, if at all we say the best function would be an EMG electrodes, placing EMG electrodes and see with this, which I guess is like, it could be hi-fi lab related one, but practically for all the clinics, as friend Nitin has said, we use a lot of these shoulder functional and stability exercises. Clinically, if we do this, most of the stability tests we do are the static tests or stability tests, but depending on whatever we can see a player during the stability ones or else in this isometric or stability test, we can have good estimation about what's happening dynamically also. Because usually if they could not activate in a simple stability or contraction test, obviously players, it's probably really impossible for them to activate during the dynamic also. So it's about trying to do this or trying to assess with our clinical test and trying to imagine or trying to visualize about what might happen during their ones. And nowadays we have all these videos. During the videos, we have all these. So I do a lot of these video ones, taking the videos and trying to do in this way and repeatedly showing the players so that we can have good estimation. Yeah.
Kind of a biofeedback kind of a thing.
Yes, it's biofeedback.
So any specific exercise or a key point for a subscapularis involvement? One of our viewers have asked this question very specifically. Anything specific to subscapularis? A key point.
Normally for subscapularis, we find a lot of eccentric strength deficit, because they keep on doing external rotator, external rotation. So they have a lot of eccentric strength deficit into the subscapularis. So we focus mainly on eccentric strength of the subscaps. The exercise which I showed was someone throwing a ball at you and you're catching the ball in a reverse direction. So the ball is going that direction, you are also catching in that direction. So basically you're doing an eccentric strength of the subscaps. You can have the patient lying down supine with the elbow out of the table, and then you can start from around 90 degrees and then eccentrically control the dumbbell going down which is again an eccentric contraction of the subscapulars. But in everything, I need to ensure that my scapula is stable. If my head of the humerus comes up or forwards, then I've lost it. So I just maintain a depression, adduction, and posterior tilt of the scapula, and then do the eccentric subscaps.
Kiran, would you like to say something on it?
Yeah, that's what I guess that's the secret. I mean, if anyone asks me about the one specific or magic exercise for the subscapularis, whatever, I would say first go to shoulder stabilizing. That would be my first choice of it, because those are the stabilizing ones. Because again, we go to this, if the proximal area, if it's not stabilized well, then going to the humerus and head of humerus stabilizing may not be so easy. So I would always go to stabilizing ones. And in this also, same in the same thing. I did not show some of the movements where we even go to drives. Player will be standing and they'll be doing lots of these ones also in this one. So in this way, again, stabilizing. And second is one more, maybe I may not think of exercise, but if at all too much of subscapularis thing, whatever is happening, probably I might even, if subscapularis is getting involved more and more, I might also go to whether how is their upper thoracic area, whether the mobility is quite good or not, or because to compensate that upper thoracic mobility, is the player trying to do more of the shoulder movement rather than upper thoracic movement would be my first thing. It's again going to the principle of relative flexibility, whether why is shoulder doing lot of movement? Is it because the flexibility is reduced at upper thoracic areas? I'm more or less going into the whole chain of action.
How much importance you would like to give to lower traps in your both of your individual programs?
Yeah.
Again,
For me?
Yeah.
Kiran, you want to go ahead?
Yeah. Lower traps, definitely lower traps are important. But again, my general thinking is at the initial stages of rehab or treatment, we might go to individual muscles, like whether it's a lower trap or else whether it's a mid trap or else whether it's teres minor, like that. But generally, as a rule, the posterior chain muscles, the bulk of the muscles, generally whatever we say is the bulk of size of the muscles also matter. The anterior chain bulk, anterior muscles are really huge. Posterior chain, the muscle bulk is less. So lower traps are very good, but at the end of the day, I normally go to, especially in sports, to compensate the shear action of the huge agonist muscles. The posterior chain action is what is very, very important. Initial stages, yes, activation, co-contraction of individual muscles we can do. But I always go to posteriorly. If you want to get to second and third phase, we can't just be thinking of one muscle, but whereas it's the whole chain of muscles, which should be really the entire posterior chain muscle should get activated, is what my personal feeling is. Yeah.
What's your
For me, lower traps, in my first slide, I showed that the scapula does a posterior tilt. In your flexion, your abduction, or any of your movements, your scapula has to do a posterior tilt. And the scapula has to do an outward rotation. So lower traps comes in both of those movements. So basically, that is absolutely key, that if your base is not strong, your building is going to fall down. As simple as that.
Great. I have a couple of more questions, but I'll take up the last one, which seems to be very interesting to me personally. By any chance, the height of player plays any role in muscle strength? I think for both of you looking from individual bowler or a badminton point of view, do you think the height of player matters?
I don't think so.
Yeah.
I don't think that it matters. I think the height is, the muscles are proportional to the length of their bones.
Uh-huh.
So I don't think it will matter. Any human shoulder's anatomy will remain the same.
Okay.
Yeah.
So like what people generally, go ahead. I'm sorry.
That's what I'm saying. Any human shoulder's anatomy will remain the same. Only what you expect at the end stage is important, and plan that into your rehab early on, and you can rehab a tennis player, a badminton player, or a basketball player, or a cricket player. The shoulder is remaining the same. It's only that what you require at the other end.
So now, since you have come to an end, I have another question which asks about, are there any consequences for a sports person which they face after complete rehabilitation of this rotator cuff injury? Do they suffer any of these after, a longer period? Any consequences which needs to be kept in mind?
Consequences in the sense negative consequences,
Yes, negative.
or maintenance work.
Maybe, I mean, both negative also, and how do they have to maintain after this rehabilitation is over and they have come back to the competitive sports?
So basically, my assessment is that if you've been smart enough in planning their rehab, then they face lesser consequences or lesser negative incidences when they return to sport. So the chances of recurrences are almost minimal. The other thing what we do is we ask them to basically, as I said, they keep on doing anterior chain, anterior chain, anterior chain. So we ask them to top up their posterior chain and release their anterior chain regularly. So just basically their programs are modified in such a way. We sit down with their SNC coaches and we modify the programs in such a way. Boss, if you've got 3 anterior chain exercises, can we put it down to 1? Instead, add 2 more in the posterior chain. So we just modify the programs, and the players even don't realize it that they've put in the extra effort.
Basically, the key lies on your rehabilitation protocol, how effective you want to make it, and you can avoid it. Kiran, do you have something to add on that?
Yeah, that's the thing. Because I mean, again, usually we have this gym program or else the strength and conditioning programs. So how much time a player needs to spend their time on the agonist or else performance muscles versus how much time a player needs to spend on the stabilizing or antagonist or posterior chain. Usually the injury history will tell them. But players usually almost all the time, they are inclined more towards spending more time on the performance muscles. But what happens, sometimes we take the injury history, or else if we take in the last 1 year, these are the injuries, these are the ones. And anyhow, those agonist or else performance muscles might come once you're practicing, once you're playing badminton, something. So now most of the times, again, initially, players, they are inclined more towards this spending more time on the performance muscles. But if you go to the injury history and we tell them, and this is again where we go to this body screening. We keep on screening the players once in a month or else something, so that what happens is, let's not wait till a player gets a tear or something, because we keep on checking this once in a month or else once in 1.5 months, something in that way. So that's the reason why the injury history of the player straight away might give us answer about how much time they need to spend in the gym on the performance muscles or else on the posterior chain or antagonist muscles. That could be my answer. Usually that's something I straight away leave it to player. Yeah.
Thank you, Kiran, and thank you, Nitin, for answering all our questions and taking us through this rehabilitation protocol in such a beautiful way. I will fail in my duty if I don't ask you this question. I know hundreds of physiotherapists who are aspiring, either look upon you for a badminton or a cricket. In case if I have to ask both of you individually, what is the message, a learning message or advice you would like to give it to young physiotherapists who want to get into sports as a physiotherapist? In case you want to give them a one advice they should follow. Nitin, what do you have to say with them?
I think I'll just say, make a goal, chase your dreams, and keep it simple to chase your dreams. Keep it simple. Physio is not complicated. We complicating it ourselves in our minds. We have to just keep it as simple as it can be. And Kiran, then things will fall easy. Yeah.
Lovely. Kiran, how about you?
Yeah, that's what I mean. I always say that, I mean, whichever is your area of interest or area of passion, carry on with that one. But again, as a friend Nitin said, most of the times, the solution for complicated cases lies in us being thorough in the basics, rather than being thorough in some hi-fi knowledge or something. And physio general, at least whatever I've seen as, yes, knowledge-based, this thing is important, but presence of mind at that time. Yes, I am seeing this player. At this time, what does the player need? And again, as friend Nitin has also said beautifully, we all know about, I mean, I guess quite a few friends who have seen this program, they must have known about phase 1, what to do exercise, phase 2, phase 3. But presence of mind is what, when should I go from phase 1 to 2? When should I go from 2 to 3? So after that, at the end of the day, what happens is, yes, exercises might be quite easy, but physio's main thing is presence of mind at that time and trying to be thorough with the basics. I always say be thorough with the basics, because those are quite, at least I've seen quite a few answers for higher level problems, at least with my experience, what I have seen.
Great. Thank you. Thank you so much. I know I can't thank you enough for your time and valuable contribution to our SIPWEB. We are trying to have you. I mean, we were trying to have you for a long time, but thanks to Asha Chitnis and Savita Ramandan to get you here today. And we hope to have you sometime for our conferences as well. With these words, thank you so much, Kiran. Thank you so much, Nitin. On behalf of whole Society of Indian Physiotherapists and hundreds of people who are watching us live right now and thousands who will watch it later on YouTube. Thank you so much for sharing all your information and protocol with us. We look forward to talking to you more about sports rehabilitation. Thank you. Thank you once again.
Thank you very much.
Thank you, Nitin. Thank you, Nitesh.
Nice meeting all of you.
Nice.
Thank you so much.
All the best, all of you guys.
Thank you everybody for joining us today. You can stay connected with us with our Facebook page and our Twitter handle, which are available on our website as well. We, as we announced earlier, SIPWEBs will now happen once in a month. We will come back to you with all the details of our next SIPWEB. Meantime, the SIP chat, which happens on alternate Friday now, will be scheduled for July 17, which details will be posted on our Facebook. Till then, please stay safe, stay at home, and keep working and take care of whichever field you are in. Thank you so much once again for joining today.